Hello, good morning, all. I don't know if you can hear me. Can you hear me? If you can hear me, please just wave your hands. Let me be sure. Okay. All right, great. It's nice to have you again today. My name is Prosper Onyekachukwu, your regular facilitator. And today we are having a wonderful one, a facility case presentation. I'd like to ask that all the facilities on the call should please turn on your video. All the health facilities on the call, please, you're encouraged to on your video as much as other individuals that want to do so. We appreciate that and we track that behind from our Zoom backend. Thank you very much. So today we are having facility case presentation. This is just a way of getting back from our facilities to learn and see how they manage our patients. We usually would want to encourage that you present to us existing cases that you are managing, the cases that you are having difficult to manage, or the case that you tend to manage. It's a way of knowing what you're doing, and then we'll have experts, both expert clients, IPs, ALT coordinators, and then academians that are on the call that will help to, correct you or suggest other ways that you should be able to manage these patients. Thank you very much. And today, we will be looking at management of treatment failure in pediatrics clients with a focus on the impact of enhanced adherence counseling and OVC services. And we have EACs. They are the implementing partners that we're presenting today. And the facility to do that is General Hospital Okwe, far in Delta State. But before then, I'd like to call on the Federal Ministry of Health to give us an opening remark. And standing by to do that, we have Omo Labake Ekundayo, who is the Senior Population Program Officer from the NASCAP Division of Federal Ministry of Health. Labake, please, you may want to unmute yourself now and go on with the opening remark from the government. Labake, are you there?
Good morning. Can you hear me now? Good morning.
Yeah, I can hear you. Please go on.
Okay. Good morning, everyone. You are welcome to another educative and impactful session on the Spike Circle this morning. As Prosper Adelia introduced the topic and also the facility that is going to be presenting to us, the practices they've used in achieving treatment failure in children living with HIV, the pediatrics. So this morning, I will implore every one of us to please pay attention, listen attentively for us to be able to learn one thing or the other, to be able to make use of it in our various facilities. So, and also I would like to speak concerning our attendance. This morning, I can see that most of the facilities joined the call late. Please, I would like to implore us all to kindly please be joining on time for us to save time and for us to be able to close the session on time. So, and also on behalf of the Federal Ministry of Health, the leadership of NASCAP, Dr. Akudo Iguazu, and the head SI, Dr. Adibobola Bashoru, I welcome you all this morning. And also, I wish every one of us a successful session. Over to you, Prosper. Thank you.
Thank you very much, Labake, for that wonderful remark. And thanks to the Federal Ministry of Health for your usual support. Again, would want to call on the CDC representative to give us a goodwill message, and standing by to do that, we have Dr. Obinna Obanufe, who is the Care and Treatment Team Lead for CDC Nigeria. Dr. Obinna, you may want to kindly unmute yourself and go on.
All right, thank you very much. Confirm you can hear me?
Yeah, I can hear you.
Excellent. Thank you very much, Prosper. And welcome again, everyone. Thanks to the Federal Ministry of Health, as usual, for this collaboration. And thanks also to the participants that diligently take out time every Thursday to listen in and learn something. While I look forward to a review of the impact of this ECHO on our program, I think since we started this case management reviews, we can actually tell that people learn some things that ordinarily they may not experience in their little niches they've carved for themselves in the ART program, apart from listening to this program. Today's topic, management of treatment failure in pediatric clients and the impact of enhanced adherence counseling, and then how the OVC services actually assists in this process. I think there is a lot for us to learn, especially at the secondary level of care, where the OVC program has been able to diligently follow up our children that have failed treatments to make sure they get them to viral suppression. So I want everyone to attentively listen in. The country director for CDC may join if she has some time. She saw the topic and she was thrilled, that we'll be sharing this kind of experience, with over 250 people currently on the call as we speak. So just take down your notes, and I'm sure that there will be experts to also guide us with questions that we may have us afterwards. Thanks again to 5-3 for this wonderful coordination, and let's sit back and listen. Thank you very much, and over to you, Prosper.
All right, thank you very much, Dr. Obinna. Please do let us maybe a chat when Dr. Mary, the CDC country director, joins so that she can be properly recognized. Thank you very much. Again, today we have two panelists on the call that will be speaking shortly after the facility presentation. We'll have Professor Stephen Oguche. He is a pediatric professor of pediatric infectious disease, and he is also a consultant pediatrician at the University of Jos Teaching Hospital, who is part and parcel of ECHO session, literally from since inception. We also have a guidance and counseling expert who is Dr. Yetunde Akani. She is Assistant Director of Social Work. She's also a clinical psychologist and behavioral communication expert at the University of Port Harcourt Teaching Hospital, among other subject matters experts that are on the call that may want to provide perspective. So I want to quickly call on the presenter, Chioma Ezine Okike, who is the ART nurse at the General Hospital Okwe, Delta State. Chioma, you have about 20-25 minute time to present. You may skip the introduction of the facility and move on to the main detail of your presentation. Chioma, please, over to you. You may want to share your screen now. Thank you. Chioma, you are muted, but we can see your screen. Kindly put it on slide mode and then unmute yourself. Good.
Good morning, everyone.
Good morning to you.
You're all welcome to today's presentation. As earlier said, our topic for today is management of treatment failure in pediatric clients, impact of EAC and OVC services. Can you all hear me, please?
Yeah, I can hear you. Go on, I can hear you.
Okay. Then today we're going to talk about some outlines, which includes the facility profile, introduction on treatment failure, the clinical case scenario, investigations and results, management, the interventions that we are taking and the outcome, the learnings, our challenges, and the conclusion. Then General Hospital Okwe, okay, is a statement, all right, it's a state-owned government hospital. But for now, our treatment current is about 2,031. Then, as a way of definition, according to WHO, treatment failure could be virological, immunological, or clinical. Then for virological failure, it occurs when the plasma viral load is above or equal to 1,000 copies per ml, based on 2 consecutive viral load measurements after 3 months with adherence support. And also, an individual must be taking ART at least 12 months before it can be determined that a regimen has failed. Then for clinical failure, it occurs in adults and adolescents when there is new or recurrent clinical events indicating severe immunodeficiency after a 6 months of effective treatment. Then in children, it occurs when there is a new or recurrent clinical event indicating advanced or severe immunodeficiency after 6 months of effective treatment. And for immunological failure, this occurs in adults and adolescents when the CD4 count falls to the baseline or below, or when there's persistent CD4 levels below 100 cells per millimeter cube. And in children younger than 5 years, it occurs when there's persistent CD4 levels below 200 cells per millimeter cube, or less than 10%. In older children, it occurs when there's persistent CD4 levels below 100 cells per millimeter cube. Then this child, the index client, she's OA, a 6-year-old girl who resides with her mother in Asaba, Delta State. So she presented at the ART clinic on the 3rd of November, 2022. With the following complaints: that she had a recurrent fever that had lasted for 2 weeks. There was also anorexia and nausea, which had lasted for a week. Then she had weight loss, which was evident by her loose fitted clothes. There was also complaints of high-grade fever, which was intermittent. Then there was no history of cough, according to the mom, and there was no drenching night sweat. There was also no history of convulsion. Then her past medical history showed that this child is a child of a single mother who is a petty trader with no formal education. And she was tested HIV positive at 3 years of age through the family index testing, following identification of the mother as HIV positive at an IDP camp in Delta State. So she was enrolled and linked to treatment. Her weight at enrollment was 9 kg. That is 64% of expected weight for age. Then her first regimen was zidovudine, lamivudine, and nevirapine. The dosage then was 1.5 tablets BD. She was also given isoniazid preventive therapy, which she completed in April 2020. Then she was also commenced on EAC, following a non-suppressed viral load of 12,935 copies per ml. That was 6 months prior to her presentation at the ART clinic. But she defaulted and her caregiver at that time became unreachable. So on a physical and systemic examination, she's a young child. She was conscious, she was alert. She was also febrile to touch, and her temperature was 39.6 degrees Celsius. She was pale and ecteric, acyanose. She was not dehydrated, and there was no pedal edema. Her weight at that time was 13 kg. That is 65% expected weight for age. Her height was 1.06 meters, and her BMI was 12 kilogram per meter square. She had a pulse rate of 110 beats per minute. The first and second heart sounds were heard, and there was no murmur. Her respiratory rate was 32 cycles per minute. She had equal chest expansion. She had good air entry, and vesicular breath sounds were good. She was conscious, she was alert, she was well oriented in time, place, and person. And there was no meningeal signs. Her abdomen was full, it was soft, and it moved with respiration. There was nil tenderness, and there was also nil organomegaly. Then some baseline investigations were conducted, and her full blood count showed that her PCV was 24%, and her white blood cell count was 6.3 times 10 raised to power 9 per liter. Her malaria parasite was 2 pluses were seen. Then her EUCR was within normal limits. To rule out TB, she was sent for a stool gene pact and a chest X-ray. Her stool gene pact, there was no MTB detected. Then the chest X-ray had normal study. Then she was diagnosed with severe malaria in a poorly adherent RV decline. However, they also queried treatment failure and also queried acute malaria. Acute malnutrition, sorry. So the management plan was, she was admitted immediately into the children's ward. Then she was administered with the following medication. She was given IVF 4.3% dextrose saline. She was also given IV artesunate 32 milligram at 0, 12, and 24 hours. She was also given IV PCM 130 milligram 8 hourly for 3 days. She was given hematinics, that's astimine. We also continued cotrimazole for her. Then there was nutritional rehabilitation. We had to link her up to the OVC team to make sure she had a nutritional rehabilitation. Then we also adjusted her ART for her weight at the time she presented at the hospital. Then there was also recommencement of EAC. We had to recommence her EAC and also give her age-appropriate disclosure. Then she was also enrolled into the OVC program. Her mother was empowered to start up the business. Then going forward, we provided her with 3 sessions of EAC. We did that through the mother since she was still a minor. So the EAC was done for the mother so as to know how to ensure she adhered to her medication. Then we encouraged the mother to change the time of her drug administration to a more convenient time to avoid forgetfulness. I also ensured she set an alarm to serve as a reminder. Then the child was also promised an incentive that will be given to her when she takes her drugs and becomes suppressed at the end of the EAC session in 3 months. Then we also ensured she had daily calls. We made sure we called her mother to remind her to give this child her ARVs. Then the OVC team were also a major part of this because they visited the home of this child. They made sure they visited that home weekly to find out their living condition and the safety of the child. There was also monthly clinic visits. The mother had to bring the child to the clinic monthly so as to enable the clinician evaluate this child. Then after 3 months of 3 consecutive good adherence, we invited the mother to bring the child for a repeat viral load sample collection. Then as I said earlier, the OVC is a major part of the success story of this child. They made sure she had, they did a constant follow-up for prompt drug pickup. They also made sure she had escort service. Whenever she came to the hospital for her EAC session, they came along with her. They supported the child with nutritional supplements, and for example, the action meal. Then they also supported the child in school enrollment. Then to the mother, they also had to give her funds to start up a business so that she can also have something to make sure the child had an adequate diet in the house. So the mother has to have something doing to be able to make that available. So there was fund that was given to the mom to start up a business. The mother was also linked to a village savings and loan association. and she was provided with a financial literacy training. Then the current status of this child as at March 2023, when she presented at the hospital, she has fully recovered from her acute illness. Her current PCV is 32%. She has gained weight because as at March, she was 16 kg. That is 80% of expected weight for age. And her post-EAC viral load is out and is less than 20 copies per mil. Her mother is also suppressed and her business is sustaining them. Then the follow-up plan for this child, there's continuation of ARVs, continuation of histamine, continuation of cotrimazole. There's also continuation of nutritional support by the OVC team and also the OVC interventions. And there's also monthly, we are ensuring monthly anthropometric monitoring for this child. And during the course of this study, we actually learned some lessons, and this includes a mix of a well-structured OVC and EAC interventions produces better results as compared to EAC interventions alone. Then provision of nutritional support for pediatric children to facilitate their recovery and response to treatments. Also, community support for care and treatment to children and adolescents living with HIV improves ARV adherence and overall treatment outcome. In addition, a caregiver's economic status has a very significant impact on the treatment outcome of a pediatric client. And we also encountered some challenges, one of which is the mother's lack of formal education and belief in faith healing impacted negatively on the initial attempt at ensuring adherence for the child and herself. And also, the initial lack of funds to offset the admission and treatment costs. But the OVC team came out, they came up with the emergency support fund, and the treatment and admission and cost was taken care of. In conclusion, HIV remains one of Africa's leading causes of mortality in children and adolescents. While tremendous progress has been made in attaining HIV treatment goals across the 395s, children's viral load suppression remains a challenge, particularly among orphans and vulnerable groups. In sub-Saharan Africa, there is limited evidence of specific interventions in orphans and vulnerable children programs to support children and adolescents living with HIV to attain durable viral load suppression. And our recommendations are as follows. It is recommended that there should be further larger scale and more empirical studies conducted to evaluate the impact of OVC services on the attainment of viral load suppression among children and adolescents living with HIV. Then very importantly, program support for baseline investigations and drugs for children and adolescents living with HIV should be made available. Thank you very much.
Thank you very much, Choma Ezine Okike, for that wonderful presentation. You may want to stop sharing your screen now.
All right.
Yeah, so for this presentation, we want to bring out two things. Apart from the clinical aspect in terms of management of our patients, we also, for the case at hand, we're also looking at the effectiveness of EAC and also access to OVC services, given the case at hand. And for this reason, we have two persons to speak in each of these areas. We have Professor Stephen Oguche, who would throw more light on how well, or if not, how bad this patient was managed and from clinical aspect of it. And thereafter, I will call on Dr. Yetunde, who is a counselor and a clinical psychologist to speak on the OVC aspects and also the EAC, effectiveness of EAC. So it's nice to have you again. Professor Stephen, if you are there, can we have you go first? Prof, please, the floor is open to yours. The floor is yours now.
Thank you, Prosper, and good morning to every one of us. I hope I'm being heard.
Yes, we can hear you.
All right, thank you very much. So this is a very good case to illustrate the challenges of children living with HIV who are OVCs. And not only the OVCs by strict definition of the OVC, but we should also be looking at children who come from very poor backgrounds, even though they have their parents, but the parents don't have the means to cater for them completely. So this also group of children will be part of our discussion today. I want to commend the team, the clinical team that managed the child. You have done very well from my own listening to your account of how this child was managed. And we just needed to highlight a few things about managing children from this type of background. First of all, we must, when we assess these children, we have to identify the major problems. OVC is a major problem. Poverty is a major problem. Children who are coming from places where there is insecurity is a major problem. And children who are coming from very far away places to access care, or those from hard to reach areas, all of these fall into those categories. And we have to identify some problems. One, when you commence treatment after you have done your clinical and laboratory assessment and you commence treatment, first make sure that you are choosing the appropriate regimen of medicine. And number two, you are also placing the child on appropriate weight-based dosage regimen. That is very, very critical. And once I have said that, I must also follow it up with the fact that children are growing. And because they are growing, their weight will change. And once their weight changes, we need to adjust the dosage of the regimen that we are giving to them. If we don't do that, then they will be given suboptimal antiretroviral drug, and then you may experience one of two things. One, treatment failure, or outright drug resistance. Okay, so we must also distinguish between treatment failure and drug resistance. So in both cases, you are going to find that if you are able to do viral load assessment, the viral load will be high, 1,000 copies per mil or more. So once you have that, you have to be considering one of two things. One, the child could be experiencing treatment failure, or secondly, it may be a drug resistance, and you need to prove. The only way to differentiate between the two is to do resistance testing. I know this is not available in most of the places, but you can do it by referral. And I think the national program used to have a donation program that attends to samples of those children in this category who you are thinking may have drug resistance, so they can help out. I think the federal ministry can speak to that. There are other important things which you have to check. Palatability of the medication is very important, and children don't tolerate drugs that are not palatable. And because of that, if they must have it, then you have to remember the anatomy of the tongue. The tongue, 1/3, the anterior 1/3 of the tongue represents the taste buds for sweet and bitter taste. The lateral 1/3 represents the taste buds for sour taste. And the posterior 2/3 of the tongue, there is no taste buds there, almost. And therefore, anything you put there, the children will not perceive the taste, whether it's bitter or it's sweet, and they will usually take it. If you remember this, then you'll be able to navigate medicines that are not palatable. Now, the other big issue has to do with adherence, counseling. And in this area, you have to watch out for parents who are aged. For instance, aged grandparents, you will have issues with adherence, so you should know that. Single parents like this one usually also have problem with adherence. And then you have caregivers who are on drugs. When I say drugs, I'm talking about particularly alcohol. So they are likely to slip through and not give the medication. So adherence may be a problem. So you need to check out this as you do your adherence assessment for the parents and the child. This child will not be able to take the medicine by herself because of her age and the circumstances surrounding her. So somebody has to do it, and it has to be the parent. So you need to assess the parent. And where there is insecurity, also, you got to also work around security issues so that the caregiver is secure and the child is secure and the medication is secure. And then the administration is also secure to enhance adherence. But adherence is very, very important. When you are considering treatment failure, one of the things you should first assess is adherence. Okay, because if the adherence is not optimum, you are going to have treatment failure and maybe down the line, drug resistance. So adherence of treatment to treatment is very important that we, assess at every visit. We got to monitor that. And in terms of monitoring, two things, we've talked about adherence, but you also monitor the weight because the dosage of medicine will be changing according to the weight. And when you do weight check, you look at the weight on weight chart. There must be a chart. If there is no chart, you will miss it because the single weight recording doesn't tell you anything. But when you do have a chart, then you will know whether that child's weight is faltering or not. So I must emphasize that you have weight charts and you chart the weight of the baby. Either weight for age or weight for height charts. They are there and we should use them. Every monitoring visit should include charting of the weight of the child. Otherwise, we can run into treatment failure very quickly. I've mentioned drug resistant testing. This is expensive, not always available, and so adherence will help us. If the adherent will have virological suppression and you will not need to do resistant testing. But if you have to, then you must do it. All right, so I think these are some of the points that we need to mention. And then of course, the medication formulation is very important. The dispersible tablets are the best for the children of this age, all right? But if you're using any other form of medication, capsules, tablets, blister tablets, or capsule, those may be difficult for children of this age. So if you do use the dispersible tablets at this age, one, it is palatable, and two, the children will take it easily with fluid. So that will enhance, optimum drug availability, bioavailability to bring about virological suppression. Thank you very much.
Thank you very much, Professor Oguche, for this wonderful insight. And then we appreciate you. Thank you for all you do for us on this ECHO platform. Before I open up the floor for questions, I still would want to have Dr. Yetunde Akani to speak on the aspect of enhanced adherence counseling and also the OVC services, if there are questions or additions. Dr. Yetunde, please, if you are there, you may want to speak now.
Okay, so good morning, everyone. Can you hear me?
Yes, I
confirm?
Yeah, I can hear you. Please go on.
Okay, so thank you very much for your participation this morning. And I want to thank Prof for his insightful comments. However, I know that Prof had actually given some expose on the questions I want to ask the presenter, but then I still want you to put the presenter on a call for me. Based on their presentation, I want to appreciate you very well for all that you have done. No matter how little service we provide, it actually makes a difference in the life of our patients. And that's why you are able to record some level of success in providing services and actually bringing back this child into care. However, there are certain things that we need to look at for. Although Professor Oguche actually mentioned some of them, but then from the part of those who manage the patient, can I have one-on-one discussions with you right now? So I hope she's on call.
Yes, Choma Ezine, are you on the call? And then
She's not the only one that managed the patient. So yes, other members of the team should be on call.
Yes, they are.
So that
we're on call,
everybody can actually make their contributions. Okay, for this patient, the patient is a child, she's about 6 years old. And so we know that this patient is completely dependent on the mother, who is the caregiver. I want you to tell me, what were the specific factors that you identified for poor adherence on the part of the child or the mother? Because it's a two-way thing. And that's why I said that Prof gave some leadway to that. But then I want you to tell us, what were the factors that you identified that was responsible for poor adherence from the part of the mother that contributed to the child not adhering, or factors from the part of the child that contributed for the child not adhering? So can you quickly tell us? Because those are the things we need to look out for. And those are the barriers. If you cannot identify those specific barriers, that's the essence of EAC. Once you cannot identify specific barriers, then it becomes difficult for you to apply specific solutions to them. Remember that EAC is a structured process. So let's start from there.
All right, Choma, can you, is anybody there to respond? Quickly, our time is running. Hello, Choma, are you there?
Yes, I am.
So,
okay, they stay in an IDP camp, and usually that place is usually flooded. So most times they find it difficult to, due to the flood, they don't come to take their medication on time. And being that the child is a minor, at some point the mother was negligent. When I spoke to her, she gave this child medication whenever she likes. She doesn't give the child at the right time. And she also complained that at some point she felt the child was fine. She had this belief in faith healing. So at some point she stopped giving the child her medication. She said God has healed the child, that she will not give the child the medication again. So she stopped. So she was not just, she wasn't giving the child her medication. Even before she stopped, she was giving whenever she likes. So I had to speak to her on faith healing, that she needs her medication to be okay. That was when I encouraged her to set an alarm. I even had to set the alarm for her so that it would serve as a reminder to give the child the medication. Then she also complained of the child vomiting whenever she gives the drug. So I encouraged her to give the child the drug with a meal so that at least to cover the taste of the drug, so as to make the child not to vomit the medication.
Okay, so thank you very much for those contributions of yours, the response. So you now see that this you identified barriers after initiating treatment. And so you never discussed about possible barriers before initiating treatment for that client. And so these are the things we need to understand in the area of counseling. If you look at it, you talked about the distance. So these are the things we want to talk about. In initiating treatment, you want to ask the client, what would be a barrier to your not adhering to drugs, to treatment? Now you've seen that there's a distance. So if there's a distance, is it possible to increase the amount, the refill? Or is there a closer place where they can actually get a refill? Those are issues that you can identify and then bring up possible solutions. Now, if you actually listen to what, if you agree with me based on what you just said, I'm not sure this mother had an initial counseling section of any sort. And that's why she could tell you that she felt that the child was healed. So we need to nip it on the bud. That's the truth. We need to understand the process of initiating people into treatment. And that's why I want to ask you, do you have a designated counselor for your clients in the facility? Or
yes,
it is carried out, yeah?
We do have a designated counselor.
Okay. And so that having a designated counselor, fine, yes. How skilled is your designated counselor? That's another issue. So because what we are now seeing, primarily you would see that it's as a result of what? Lack of what? Information. The person is not properly counseled on the process of care for this particular child. It's good that you've identified some specific barriers to poor adherence on the part of the mother. And then basically for the child, you heard what you said, that it's about vomiting. And that's why Professor Oguche was telling you that it's better, it's more palatable when you give them dispensable drugs. So these are things that you need to look out for. And so if you don't have those ones around you in your facility, then you start thinking of how to get them elsewhere. Then it is also very important for us to understand that the process of disclosure, you told me you did age-appropriate disclosure process. What was the age-appropriate disclosure that you did? So have you disclosed to that child? Is that what you're saying?
We've not disclosed to the child.
Okay, so what were the age-appropriate? So I want to know what were the, let's be more specific. These are practical things. Let's bring it out so that everybody can share in the learning process. So what were the age-appropriate disclosure process that was followed? Because I know that we discussed that. Yes.
For her age, you told her, we told her that she needed to take this medication to be healthy. And because at her age, she knows about germs. We had to tell her that there are germs, and there are some germs in her blood which she has to take medications for so as to be healthy. We didn't actually tell her what she was suffering from, but we told her she needed to take this medication so that these germs will not harm her.
Anyway, so that was also done after the treatment failure, not so? Yeah, not before. So, however, for that age appropriate, I have some issues there. The mother in question, you said she's an illiterate, right? She's not educated. Is that what you said? So how much does she know?
I didn't get that, please.
Yeah, I was just trying to connect your process of disclosure, appropriate disclosure to the child, and that of the mother's educational level of understanding. We have age-appropriate messages. We have developmental ages of children that need to be looked into before you discuss with them. So it might not be you who did that counseling or whoever who did it. You needed to engage that little child because she's 6. And so although I know there are some 6-year-old children who are very, very intelligent and even have a higher IQ than their age. So, but then you need to assess the understanding of that child very, very well. And for the child to understand what we are talking about. And you know, this age is a very challenging age for adherence for children. But then in most cases, it's a better age because children obey parents at this age. It's even when they're a bit older, they want to know why they are taking drugs. Why do I take drugs every day? I don't want to take the drugs anymore. So it's easier at this point, except if maybe the drugs are not too palatable and then it's making the children feel very uncomfortable. So these are the things we need to understand, because for EAC, when you say you do EAC, you want to be very specific. You want to identify the major factors that are responsible for poor adherence or non-adherence. And you have talked about distance here. So in the long run, do you think that that distance could still cause poor adherence for that child? Because for now, you've just done, you've had just a few sessions with them just in the past 3 months. And so it's a continuous thing. And so people need to understand the process of treatment and care and the outcome of care. It's very, very important. Then you talked about the OVC. You know, the OVC has different priority areas. There are some that is focused on the child and there are some focused on the parents. But then you know that this process at some point might not be sustained. So what are you putting in place as a form of sustenance for this mother? What do you want to do for her? And that's why I will still encourage. I don't know what is obtainable in your facility, because you also talked about that some of the challenges you had was that the mother was unable to offset their hospital bills. And that could also be cause an hindrance, because when they remember these things, they might not always want to present to the clinic when they are sick. So do you have a welfare unit in the hospital? There's a social welfare unit where you can actually report issues like this? Or I'm still talking about the importance of multidisciplinary team approach in caring for our patients. And that's why you need to think about social services that are available. The essence of it is for sustenance, because you see, this child is still very young. She's 6, the mother is single, so she has a lot of issues on her mind. So we need to put things in place so that we do not actually lose out on this particular case anymore. So you now find out that, like you said, counseling is essential, but not just EAC now. The initial counseling section is a bedrock for adherence. We must take it that way. Either we like it or not, that initial sections we have with our clients goes a long way to determine the success of their being adherent to care. So what I'm trying to say now, there is a need for whoever is providing these services to continually assess their skills and then develop them. Because what we are saying is that from the beginning, once you are initiating treatment, we want to start identifying potentials for non-adherence in a client. And the only way you can identify potentials for non-adherence is when you actually explore. And what do you do? Remember that there are different potentials for non-adherence. It could be economic, could be social, it could be psychological, a lot of other factors. It even could be medical reasons. It could be belief system, cultural systems. So there are a lot of issues. So identify those potentials for adherence, and then you start dealing with them with the clients. And then that means that you are helping them to build their coping skills so that when it comes up, it does not really challenge them to the extent that they will fall out of care completely. So in summary, you look at, you've done so well, you tried for this patient. But if you look at it, there was even break in communication at some point in time. So maybe it was because the child was actually sick. That was why she brought back the child. So they need to understand the process. What happens? When this happens, this is what you get. When you do this, this is the result. So you must always communicate the benefits of whatever process is on ground. Thank you very much.
Wow, thank you very much, Dr. Yetunde, for that well-detailed perspective. And thanks to Professor Guche. So now we see where we needed to have improved, especially things that we needed to identify prior to treatment initiation and all. So now, do we have questions from the facilities, questions from AQs, questions from other implementing partners? So I have Wilfred from Lagos. Wilfred, I've just enabled you. Can you mute yourself and ask your question? Wilfred, Lagos.
Yes, I'm here. Can you hear me?
Yeah, please, a quick one, just ask.
All right, very good. Now, regarding the initial encounter, was there documentation in the adherence strategy work plan? There's a form called adherence strategy work plan. Like Dr. Itile was saying, that initial adherence, was it documented? Then was also this adherence follow-up forms, where they filled. When you have the initial clinical evaluation, you also have the initial, that's adherence strategy work plan. Is that documented? If we do an audit of your process, are we going to find that they're at the back of the care card? Was it documented in the back of that care card, the adherence, that summary page at the back? So is this available in that facility? Is that form available in that file? If any of us is interested and wants to see that, is that available? Thank you.
Thank you very much. This is typical of MIE question, because we know what is not documented is not done. So Chama Ezine, I don't know. Can you, it was what his concern, can you address it quickly? Even though we don't have any evidence to that, except I sent someone now to come and meet you. Chama, over to you. Can you quickly respond to this?
Any intervention we make on any client, we always document. Whatever is not documented is not done. So it's everything we did is being documented in her folder. Behind the adherence part of the folder of her care card, documented there.
All right, sounds good. So can we have Aremu John Tunde, State Clinical Mentor for Gombe? A quick one, please.
Yeah, thank you. Can you hear me, Prosper?
Yes, loud and clear.
Thank you very much for the wonderful presentation. I was just looking at the introductory part of your slides. And you said that defining treatment failure, the client have to be on treatment for 1 year. I just want to ask, is that your first HIV viral load estimation, do you do it after 1 year? Because there's a basis in which you define treatment failure. Your first viral load is done at the end of 6 months. And it's from that time that you can actually define treatment failure, not 1 year. I was just not sure whether it was a mistake or it was the new thing you're trying to push to us. Thank you very much, Anova.
All right, thank you for that observation. So Chama, can we have you respond to that, or any of your team members?
The first viral load is done after 6 months of taking ARV.
Yeah, that is a standard practice, but was it what you presented?
Yes, that was what was done for this client.
Not 1 year?
Our first viral load sample was collected. No, not 1 year. It's 6 months. That was what was done.
All right. Let's have APIN Plateau PSSH. Can you please unmute yourself and ask your question quickly?
Okay, good morning. Thank you, Chama, for your presentation. So I have 2 questions. The first one is, which nutritional supplements did you use to manage that blood? And secondly, I saw that you calculated the child's BMI. I thought BMI is supposed to be calculated strictly for adults, not pregnant and children, pregnant women and children. So why did you do that? And why not use the mid-upper arm circumference tape? Thank you.
All right, thank you. Chama, over to you, please.
Okay,
Hello, Chama, are you there?
Yes,
please. Sorry. I hope these questions are not too much for you. Your team.
I should ask someone from the team to help answer the question. Why she take? Yeah, she's been speaking all day long. You know, someone she should take a break, take water drink. Someone else from the facility should help. You know, it was a teamwork basically. So let's have folks from the facility join in. Okay. So all right, go on and respond. Okay, quickly.
Okay. Well, the nutritional supplement is a locally prepared combination made from soya beans, groundnuts, crayfish, and a little amount of milk, just maize, just combination of cereals that will improve her nutrition. Then what was your second question, please? Okay, BMI can be calculated for children from 6 years and above. So that was why we calculated her BMI, using her weight and her height.
She asked why not the other? Why not the, she gave an alternative. She asked why not that one? Why BMI?
What was the alternative?
Who asked that question again? Okay, I think we've lost him.
No, she said mid-upper circumference, but
yes.
it's relevant.
Yeah. Okay. So can we have PH, Central Hospital Tula? Can you quickly ask your question, please? Or meet yourself and ask your question. Are you there? Yeah, quickly, please.
Good afternoon. We wanted to know at what age or what would be the range of the age in which a child is supposed to be exposed to his stature, because it's been brought up, but then the answer wasn't given. So we want to know.
All right, thank you very much. Can I have Dr. Yetunde respond to this in 1 minute?
Okay, thank you very much. We need to understand that disclosure is age appropriate. And that's why the service provider or the counselor, whoever one is in charge of the disclosure process, there are factors that you need to take into consideration before disclosing. And so that's why we said age appropriate process. And I think when we discussed that the last time, we have 4 domains to that. We start from giving them information about what HIV is, how it is a germ. You don't need to call that name, especially when the child doesn't even understand. But then the easiest way for them to understand is that these things are germs. And so once they move higher, you assess the child's understanding and then their interpretation of what you tell them. And so as the child goes up from 10 to 12, the child should be ready for proper disclosure. And so the child at that age of 12, the child should know that they are living with HIV, and then continuously from there. But that is we are talking about the appropriate, the standard procedure. But then it is left for the service provider to actually determine whether this child is ready for disclosure or not. So if you feel that that child is still not ready, then you still need to take them up more. But remember that in most cases with children, it's even their parents that is the problem, because they are scared. They keep telling you that, are you sure these children can manage the information? And so that's why the process of disclosure starts early with the caregiver, whether they are mothers or their fathers or their parents. You let them be involved in the process, and so that they can now also see the level of understanding that the child has been able to exhibit, and they are sure that, okay, this child is ready for disclosure. Help them to understand the importance of disclosure, to care, adherence, and positive outcomes to their treatment. So these are things. So that's why I said it's age specific. And then you need to go through it. But I think we discussed this the last time. So I might also share that. I'll send it to Prosper so that you can actually share it out for us to see again.
All right, thank you. So you can send that to me via my email. So an addendum to this question will be, what happens to those that are mentally deranged? Which, in my understanding, even age will not solve the problem of knowing when the disclosure should be given to them. What's your take on that, Dr. Yetunde?
Okay, so you know that that's one major factor to disclosure when people are not mentally stable, and that's why they have a caregiver. So the people you are working with now is their caregiver. Because when you say someone is not mentally stable, it means the person might not be able to take decisions on their own, might not be responsible for themselves. And so that's where the caregiver is now the focus of the discussion.
All right. Thank you.
But
so
remember that issue, that health issue can also be a challenge for adherence and accepting of care. So, but then I also want to add something that is very, very important. We need to understand the relevance of support group in helping people to live positively in the course of care and treatment of HIV and AIDS. So maybe for some time, we've not been doing that. Identify support groups that are available within your area, networks, and then refer people for that. That's where referral and linkage works. It's not just about people coming to take drugs, treatment. No, there are other social issues that needs to be taken care of. There are other supports that people need. And so when they go to those places, they can actually find those supports. We might not be able to give out all that to take care of the needs of this patient. And that's the essence of the support group. So identify support groups, functional support groups that are not politically driven within your networks, within your facility, within the area where you are offering care for people, and then link them up to services.
All right, thank you very much. We have Dr. Obinna, but Dr. Obinna, let me have you speak class. Can I have POP3? I'm just calling you. You didn't name yourself very well, but let me just give you the grace. POP3 guest, can you unmute yourself and ask your question? POP3 guest, your hand is up. Are you a human being? If you are not, or is it a robot? POP3. All right, I think the person is not ready. So Dr. Obinna, can we have you, please?
All right, thanks. I would also just lower my hand and speak. I'm sure we're already running out of time, but very quickly, I was taken aback when the accused responder said they are not given age-appropriate disclosure, and I thank Dr. Akani for bringing this up and also shedding some light. I recall she has done trainings on this disclosure, not once, not twice. And I think it's actually a complex thing and very difficult at this time. So one question for Dr. Akani, do we have is a job aid for healthcare workers that they can just a one-pager on the steps to disclosure, apart from the training and the plenty information that we give in trainings that people do not apply diligently? I think if we have a job aid for healthcare workers and a job aid for people in the community like counselors to use for disclosure, that would be very helpful. Can you just respond to that? If we do, I think we can, I would like to have that at our own level, then we can now enforce implementation to improve the way people deal with these issues of disclosure across our partners.
Okay, Dr. Obinna, thank you very much for that. Okay, so what we are going to do is that we can sieve out from those presentations and then create our own job aids, because we have job aids all over for disclosure for children and adolescents. So it's just for us to see them and then put them together, and then we can actually work on them, edit them to fit into the populations we will be talking with. So I'm going to send you some of those documents so that maybe we'll just work together on that and then we'll get something out for our service providers.
Okay, excellent, thank you. So Prosper, please do the connection via email so that we can plan to have that document ready, and also probably presented and shared on this forum at some point. Thank you.
All right, I will do that. Thank you very much, Dr. Yetunde. Professor Oguche, can we have a final word from you in just 1 minute or 30 seconds, please? Prof, are you there? Professor Oguche, are you still there? Okay, it seems he's gone out. Okay, so Shoma, can we have a final word from you and from ACUS? Shoma is in the presenter. Can we have a final word from you, or can we have Shoma? Joda Shoma, I can't see you again. I just need.
Yeah, all right.
Okay, I just need a final word from ACUS or from the facility. A quick one.
All right. So good morning, Prosper, and everyone. So this is Dr. Frank from GH Okwi. We are grateful for this opportunity to present on this platform And we equally thank Prof and every other person who has given us feedback in areas we should improve on. We are hopeful that we are going to do better going forward. Thank you very much.
Thank you very much. And thanks to AQs, thanks to Dr. Shama Helga for all the support and all of that. We look forward to another IP presenting last Thursday of next month so that we continue learning from each other. Let me call on ZDC to give a final word, and then we'll take a closing remark from Federal Ministry of Health. Dr. Obina, let's have a final word from you, please.
Right, thank you so much. I think having worked in this field for a very long time, I actually benefit at every opportunity to listen in and see real life experiences. So just to affirm that people benefited from this, I've just said, I've just done the thumbs up. So wherever you are, I want you to do a thumbs up if you benefited from this activity today. And on a final note, I'd like to say thank you very much for listening. Let's see how many thumbs up we're getting. Thanks to EQ's team for the brilliant presentation. We'll continue to learn. Thanks to 5-3 for facilitating and always being there to bring us together. Thank you very much, and over to you.
Thank you very much. Thank you very much. And let's the Federal Ministry of Health. Can we get a closing remark from Federal Ministry of Health?
Okay. Thank you, Prosper. Thank you, everyone. And I would like to say a very big thank you to EQs and the facility that presented today's topic. We really appreciate you for the good job that you people are doing at the facility over there, and also for taking note of the observations and the input from all other persons on the call. And also to our panelists of today, Dr. Akani Yetunde and Prof. Oguche. We really appreciate you for your invaluable contributions all the time. We really appreciate you from this end. And to CDC representative, Dr. Ogbanufe, thank you for being on the call. And to all other IPs from APIN, IHVN, CIHP, EQs once again, and to all others that I'm unable to mention, thank you all. And to all our participants, thank you for always joining the call, and for you for the good job that you people are doing at the your various facilities. And I believe that we've learned a very good lesson today from this presentation and from all other input from our panelists, from CDC representative, and all other participants that contributed this morning. To also Dr. Aremu, thank you for contributing on this call this morning, and also for your usual participation. And to all other IPs on the call, also my NASCAP colleagues, and to 5-3, thank you for your usual technical support. Really appreciate you from this end. And on behalf of the Federal Ministry of Health, once again, the leadership of NASCAP, Dr. Ikpeazu, and also the NSI, Dr. Adibobola Bashirun, I wish every one of us a blessed Thursday. Hoping to see you all next week. Over to you, Prosper. Bye for now.
Thank you very much, Labake. Thanks to NASCAP, and from all of us at 5-3, myself, and then Miriam Olawe and the rest of the team, want to say thank you. Kindly look forward to us sharing the link for the recording and then the presentation and other document that we may get to share. So thank you, and see you again next week. Bye for now.
Bye.